And Cody, I will go ahead and hand it over to you.
Well, wonderful and good afternoon or good morning for those of you who may still be in Central Time, and it's just 11 a.m. It's a pleasure to join you now 2 weeks in a row for our next Lunch and Learn that we're doing through sponsorship from the Flex. Today, we're going to talk a lot about interfacility transfers for behavioral and mental health patients and looking at what that looks like. So let me make sure. So I do want to first shout out and thank my team that works with me each and every day on this. We met this morning to finalize a few things and start working on our next webinar, which I'll talk about towards the end. But to Hancock, who is doing her doctoral studies with us, and then Susan Gresham, who is our program manager for the Center for Rural Migrant Health here at Purdue University West Lafayette. As I mentioned, a huge thank you to the Indiana Department of Health, State Office of Rural Health, who has provided funding to us through the Flex Initiative, which is funded by the Health Resources and Services Administration, or HRSA. And thank you to Allie, a good friend and past colleague, and the Indiana Rural Health Association for hosting us today as well. If you were here last week, so last Thursday, we did an intro or a primer on behavioral health and talked a lot about some of the trends and the needs that we have, but then we recognized that there's two areas of further support that we want to make sure we did a deep dive into. First is interfacility transfers, which we're doing today. And then in May, on May 6th, we're going to be doing telehealth and telebehavioral health and what that looks like and some tools and supports there and some actions to support there. Last time we talked, our Boilermakers were still in the tournament. We had a valiant effort on Saturday night, but unfortunately, Arizona was just too good to beat that night. So we are out, but we had a good run on that. And now it's football season. The spring game is in 2 weeks here. So, okay, so as we start and talk about the basis of interfacility transfers, we first want to talk about using this from a patient safety approach and what is a transfer. So, an initial definition, an interfacility transfer is when a patient is at one facility. That usually is a facility that has long-term staying, so an overnight, either a hospital or an ED, where they're maybe being boarded, and then they're moving to another long-term facility. So, another hospital, acute care hospital, a behavioral health facility that has residential components to it. And that transfer has to be done in a way that is safe for the patient, but also safe for those who are doing the transfer, and is not one where the patient necessarily can transport themselves or a natural support can transport them, but an external support needs to do them. So first off, we need to talk about what are the bases of some of those things. And I do have, trying to figure out here. Okay, trying to get I do have the chat and the Q&A open and need to get my screen set up appropriately. So we look at the initial for the basis of some of those transfers. So what are the benefits? What are the risks? And what do we see? So among the benefits of interfacility transfer to patients are access to a higher level of care, or a specialized diagnostic testing or procedure that may not be available at their community hospitals. When we think of behavioral health, there may be other types of therapies that a facility is not able to, or it may be that that's a behavioral health unit that is designed to support the patient in the condition that they currently have, instead of being a medical hospital where they are on a normal acute care med surg bed and don't have the group therapy or the specialist that can support them. However, transfers may also introduce risks related to this continuity of care that potentially can threaten the patient's safety. Existing literature on transfers to academic medical centers suggests that transfer patients have worse outcomes, i.e., increased length of stay, increased risk of adverse events, and increased mortality. But there is broad variation in the reasons why patients are transfers, and more studies are needed. The first step in any patient transfer decision should be an analysis of the patient's potential risks and benefits. While we recognize that length of stay may be longer for behavioral health, it may be that there are any treatment facility designed, as I said, for that. So therefore, the protocol of treatment is longer than if they're in a med surg bed where the specialist or the hospital is taking care of them don't have that area of expertise. As we dive deeper into what are the risks associated with transfers, well, one is a lack of a standard process. A lot of facilities are saying, okay, I have these patients, they are coming in. We are not the best source of care for them. And we really need to identify where is the best spot for them to receive the support. So there needs to be a standardized process. There needs to be a discussion. We'll talk about that further on in today's lunch and learn about how do we initiate that initial connection with a provider group. And then once we have a patient who we've identified and is medically necessary for transport, how do we initiate that transport? How does it get reviewed? And what's the approval process for that? It's also important. We've talked a lot in the rural health space this year about the GROW initiatives and the RHTP initiatives, but how do we share that information between the facility that has the patient currently and the facility that's going to receive the patient when they're transferred? How do you make sure that it's not incomplete or inconsistent information and that vitally critical information that's necessary is transferred? We also know that transfers take time. It takes a staff in rural. The ambulance or the service that's doing the transfer may also be providing 911 support, so we have to wait until there's a lull, which then creates a lot of difficulty about when the receiving facility is going to receive the patient. So we need to talk about delays between transfer decision and patient arrival, and what is the protocol from when the patient is accepted for transfer and when the patient arrives. If I'm still in what I call the host facilities ED, for example, when does the protocol of treatment change the receiving treatment's protocol? Each facility has their own protocol, and for various reasons of medical licensure and things, those need to be followed. But if we're changing that protocol, at what point do we start to make that change? And how do you minimize that delay so the patient gets the best support that they need? There's also transporter variability, both in training and skills. And we'll talk about, is this an EMT-based rig, ambulance that's transporting the patient? Do they need paramedic level support? What's the availability of that support? Or is it a vehicle, a car or an SUV that can do the transport instead of an ambulance that has a gurney, for example? And then lastly, that transfer timing. Healthcare is open 24 hours a day, 7 days a week, 365 days a year. But there are parts of our healthcare system that is still banker's hours. They're 8 to 5 Monday through Friday or 9 to 5 Monday through Friday. So what happens when a transfer is needed in nights, maybe at 1 or 2 in the morning on a Saturday or Sunday, as we're entering a holiday weekend this holiday for the Christian faith, but for other holiday weekends, how do we support that transfer? And the accepting facility staff has the potentiality to be reduced. So what are the roles, and what are some definitions that we're going to use? So the interfacility or the hospital transfer, that's the transfer of a patient from one inpatient facility to another. So that maybe that is from the emergency department at a facility into a treatment facility. Maybe that is from a med surge, a PC or ICU level, maybe not for behavioral health, back into a different level of care. There's the referring or the sending facility, the facility where a patient first presents for treatment or where the patient currently is for treatment. There's the accepting facilities team that reviews and approves the transfer requests, the ones receiving or accepting the patient. There's the transport team, the team that physically moves the patient from one facility to another. And then the transport, and finally, the receiving team cares for the patient in the accepting hospital. So they take care of the patient when admitted to the accepting hospital. So there's a lot of components here that need to be worked through. And I think as we think of rural health, and we think for critical access hospitals specifically, those that are supported on the Flex initiative, it's ensuring that everyone on the team at all shifts understand what are our accepting facilities, what are the protocols for them, and then what is the process for the receiving facility team to ensure that they are receiving the patient appropriately. So what are key functions in the transfer eligible patient? So Dr. Thomas Washi, who is a dual MD PhD at the University of Michigan Center for Clinical Management Research, identified 4 components of the transfer process. These are identifying transfer eligible patients, so identifying early in that treatment protocol that they are eligible for transfer, or maybe they would benefit greatly from having a transfer. They are then identifying a destination, so who is that receiving facility? It's negotiating the transfer, and then lastly, accomplishing the transfer. And we're going to break these down into the recurrent issues associated with each one. So first is identifying the transfer of the eligible patient. In establishing whether a patient is eligible for transfer, clinicians or referring facilities consider whether our hospital has a protocol for the patient's conditions or situation, whether the facility has the capacity or the capability and the capacity to handle the treatment and for handling possible complications from the treatment. We also need to take into can account the patient's age and other demographic factors, as well as the patient's health insurance status. So as we're talking, especially around behavioral health, that we need to recognize, are we looking at a pediatric population? Are we looking at a traditional adult population? Or are we looking at geriatric population? Each of those populations are going to have very unique, different types of facilities that are going to receive them. And it's on the critical access hospital to identify what are the protocols, what is the closest facility, and for each group, what is the best facility to support them in that. As we're identifying a destination facility, six factors play into the decision. Existing institutional relationships, and this is what we always, uh, sorry, uh, excuse me, institutional relationships. So what is out there is they are we already part of a system and system owned, or do we have existing relationships with other partners? The routinization, this is what we always do type thing, and who do we constantly call? What are the insurance mandates? And some insurance and payers require certain types of facilities and certain types of situations for other transfers. So how is social work or other individuals at our facility supporting that insurance mandate? What is the quality and proximity of the destination hospital? As we are elevating this patient and we are moving them, we want to ensure that their natural supports or loved ones are close and easy access to them. But then also we want to ensure that the quality of care that they're going to receive is just as good or if not better than what they would see if they would have here. Is the patient a pre-existing patient and has that pre-existing patient and doctor relationship? If the patient has been transferred before, were they pleased at where they were transferred? Or if they've not been transferred before, is there an outpatient setting that they normally use that they would be able to be transferred to? Then lastly, what is the preference of the patient? And what can the patient really do? So in Washi's work, research suggests that the referring hospital could make a choice of where to send each patient to get the best care for the patient. In practice, however, transfers are shaped by broader interorganizational relationships, which do not seem engineered towards optimizing care of individual patients, but rather driven by organizational focuses. So again, it's important as your system is thinking through where do we send patients and what is the support network that we identify in that interfacility transfer of do we have those norms already placed there? Lastly, we need second or third, excuse me, we need to negotiate the transfer. We need to understand, is this a dump? So this is something that we see a lot in the literature when we look at interfacility transfers, is some facilities don't necessarily want to receive a patient. They feel like it's just a patient they're receiving because the other facility doesn't want to care for them. Now, granted, there may be opportunities and times from an insurance standpoint or a payer perspective that patient needs to be transferred from light care to light care, but usually there is an elevation of care that is needed here or more specialized care. They don't need acute medical care. They need acute behavioral care. So we're going to move to a behavioral health facility in this example that's more specialized in that. Is contacting the receiving patient and ensuring that they're appropriate to receive the patient, that they're comfortable in that. Then lastly is the timeliness of phone calls. So as you're negotiating those things get very busy in transfers, but ensuring that both sides are engaging quickly on the phone and supporting moving forward. And then lastly is accomplishing the transfer. Some will say that this is the hardest step, so it's easy to identify the patients that need to be transferred. We already have existing relationships, existing partnerships supporting of that, but how do we identify and actually get the transfer there? One is, do we simply have the EMS or the other partners that are able to give the transport? Does the receiving facility have a team that can come in and receive the patient and transport them back to the receiving facility? Or is it the obligation of the sending facility to identify what that transfer is? How do we prioritize if we have a limitation of how many ambulances are available or other transport options are available, different patients, and how do we balance that with the timeliness of need? How do you synchronize medication? Again, that communication, understand the protocol. So there's a medication that needs to be given Q6. How do we make sure that we know what that Q6 is and how do we ensure that we're sharing that? And then lastly, how do we process that paperwork and ensure that that medical record is being shared with the receiving facility and ensuring that all paperwork is necessary? So as we're thinking through, or as your facility is thinking through interfacility transfers, I think it's really important to have an understanding of how do I quantitatively measure this moving forward for quality and safety of the patient and of their. Um, again, it's always hindsight after the fact to say, oh, I wish I collect that data, but hopefully some of these are the things that you can keep in mind as you're developing it or implementing or expanding your current IFT transfers. So one is the number of transfers accepted, declined, and canceled by accepting facilities. So as you're transferring out, you may have multiple partners. Who is most likely to accept? Who's most likely to decline? And then those of who have accepted, what's the cancellation rate before that patient can be moved? Of those that have declined and canceled, what is the reason for that? Was there a higher level acuity of need of another patient at another facility, so they took the only available spot at that facility, or was there a different piece there? In interfacility transfer literature, especially for the behavioral health, one of those is understanding was there a patient death within 24 hours of the transfer, and recognizing the acute criticalness of that transfer and what was needed. Is there a need for a change in level of care? For example, are we moving away from a med surg facility, maybe into a PC or an ICU facility if there's a medical complexity, but then also partnering for behavioral health, are there other areas of care and that was needed there? The length of time on the transfer list. I'm sure we all have stories of either people we know or people that we've talked to that spend long times waiting for transfer, waiting for either the facility to have a capacity to receive or the EMS service to do that transfer. So how do we reduce this? And are there certain partners that allow us to have these transfers be done more um, faster? Pardon me. Safety reports that identify near misses or adverse events. So were there different things that we as a facility should have pushed for that transfer to occur quicker because there's a safety concern there. Inclusion of transfer-related safety events as part of the MMR, morbidity, mortality review process. And then lastly, shared case review. And I think this is important, including all entities involved in the transfer, utilizing Patient Safety Quality Improvement Act privileges, confidentiality protections to really have a discussion of, okay, these are the patients that we identified, these are the patients that you accepted and we transferred. What could we as the sending facility have done differently or better to help out the receiving facility, and vice versa? What knowledge did the patient not know about the receiving facility that we could have shared with them before the transfer to ensure that transfer was as best as possible moving forward? So in interfacility transfers for mental and behavioral health patients, what are we seeing? So first off, I think it's always important that we start with some data and the context of what we're seeing right now. So we look at ED visits over time. That's the blue lines. This is 2008 to 2015 on this chart. We have various different data points throughout, going all the way up to January of this year. But we see that the utilization of the ED has gone up in ED visits, but for that mentally health related, they've gone up faster and continually to go up. So what have we seen? So we've seen increases in trends into the 2020s. We see the highest among children and adolescents. The youth mental health visits have doubled from 2011 to 2020. Suicide-related emergency department visits have increased by 23.1%, and we've also seen a significant increase of substance abuse ED visits as well. So we look at this data. If we first look at 2006 versus 2014, this is rates per thousand. If we look at, the top line, if you're driving or can't read your screen clearly, so the top is other substance-related mental health disorders or diagnoses in the ED. Second is alcohol-related mental health diagnoses in the ED. Third is suicidal ideation and intentional self-inflicted injury diagnoses. Third is mental health substance abuse ED visits resulting in an admission. So not all ED visits result in an admission. Then lastly is mental health substance abuse ED visits per 100,000 people. So as we see from 2006 to 2014, we saw a remarkable increase, especially around suicidal ideation, around other substances and mental health, but then also ED utilization overall. We look at more current data, so if we pull data from 2023 to 2025, depending on these trends, and I apologize, again, these are the same orders, we see there are significant increases. So that orange bar now is the 2023 to 2025 data. This is the most current data that we see. And we see other substance-related mental health ED diagnoses has more than quadrupled, if not 10 times. Alcohol-related has increased. Suicide has increased. If you notice the green bar, the 2006 bar is barely noticeable based on the trend and growth that we've seen there. Admissions, though, has not increased as exponentially quick as we've seen in these other areas. So while we're seeing a lot more in the ED, that interfacility transfer may not be as necessary. Then lastly, mental health and substance abuse. per 100,000, again, has increased more so from 2014 to 2023, 2025 than what we saw in 2006 to 2014. If we do a bit deeper, so the CDC every month will release data, and we're looking at all, and this is urban and rural. The data at this level, we can't really tease out the rural. So this is going as of February. So as of, I guess, 2 months ago now that we're on April 1st. But what trends do we see? So we're going to show five or six different graphs, and if you're looking, I'll try to highlight these. I encourage you to look at the scale because the line is going to look very similar on all of these, but the scale of the y-axis, the vertical side on the left side of the graph, is going to change for each of these. So if we look at mental health related ED visits, we saw there was a spike in 2020 during the pandemic and hit almost 8,000 ED visits per 100,000 individuals. As of February 2026, it's hit 5,114. But it's there is some cyclical temporal trends of what we see towards the end of each year during the holidays, but it is pretty level and leveling out right there, that 55 to 5,100 level. If we do a deeper dive and we zoom in on each of these different areas of diagnoses, we look at anxiety. So notice the graph looks relatively similar, a flat with a spike during the pandemic, but we see the scale now is between 2 and 4,000, really offering about 2,500 ED visits per 100,000 individuals as of February. Again, be thinking through which of these does your facility think that you can handle and support in an inpatient setting, and which of these are going to be interfacility transfers, and if so, what are the partners you need? Because each of these diagnoses may cause for a different partner, a different type of care setting, I should say, to support that, and do we have them? So this is anxiety. Next is our depression at 1,544. Again, similar graph, but leveling out there. We look at trauma or stressors related disorders. Again, the scale here is dropped all the way down to 4 to 600, but still about 409 visits per 100,000. And then last, bipolar, again, about 438. And then lastly is schizophrenia related ED admission visits right there around the 400 mark as well. This is if we go all the way back in time, if we go back into the 1970s and looking at decreases in mental health resources, we've seen a decrease in the raw number of hospitals that we have, and we've seen a significant decrease in the number of hospital beds that we have. So while we're seeing an increased need of support, we're seeing a decrease in the availability of resources, again, meaning that patients are going to have to travel to get to the resources that they need. So what are some overall summaries that we see? So we've seen an increase in ED visits over time from 2008 to 2015, and that's included into 2023 to 2025 data. We've specifically seen this increases in the substance use, substance misuse space. We can talk during the Q&A and tease out some of the different substances related there, but the opioid, the heroin, the stimulant epidemics that we're seeing. And then we're seeing a significant, and I'm talking exponential increase in suicidal ideation and intentional of self-inflicted injuries. This is leading to needing more and more increases, greater of 56% in the last 7 years, 2015 to 2008, associated with that. We look again at those needs for transfers, looking at CDC data. What used to be in 2012 around 600, we're now back up to around 1,100 sorry, 1.1 million. These are in thousands. I missed that. 1.3 million in 2015, and current data has not been released past 2015. The way we're tracking that data at the CDC right now, but we anticipate that is increasing. So having these partnerships designed are really, really important. So as you're thinking about transferring patients, it's also ensured that we are not only ensuring the safety of the patient, we recognize that in these transfers we're doing so because we're getting again to that higher level, more appropriate source of care for the patient based on their diagnoses and the treatment necessary for them. But we also want to make sure the transporters, those who are driving them, are protected and supported moving. Some real world examples that we've seen is a female punched an EMT in the face. They attacked the crew with pepper spray that was on the body. Things to ensure that your EMT staff are trained on. Another example that has been recently reported about was a male escaped from the ambulance after scuffling with the EMS crew. And then as they're coming out of the ambulance, they're fatally struck by a moving vehicle, which is a travesty. And the last day, a male escaped restraints, put paramedics in a chokehold and police were required to detain with a stun gun to break up that situation. So again, I think it's important as we think through these things, thinking, okay, how do I get the patient transferred? But then what are also some of the overall supports that I need to ensure that my team is ready to support them moving forward and supporting them move uh, better. So, what are some underlying issues? So, primary reason for increased risk of injury to patients and transporters is that there are no overarching guidelines for these types of transfers. Guidelines that do exist are often institutionally specific and don't consider all aspects of the transfer or conflict over what the rules and regulations should be, and overall cause confusion associated with those. In the absence of overarching guidelines, identifications of best practices help maintain a high standard of care and safety of our patients through the core medical principles of beneficiaries, patient autonomy, non-maleficence, and justice, and as well as reduce the risk of injury and harm to the transporter. So, as you are establishing these things, I strongly encourage facilities, if you're not doing the transfer yourself, having discussions with individuals doing the transfer. So if that is your governmental supported ambulance service, or if that's a private ambulance service, supporting those moving forward. I apologize. My computer just did something weird. Check that. I apologize. Are we still seeing slides? I hope so.
Yes.
Okay. I don't know what happened there. Apologize for that. Okay. So risks to transporters. So not only are patients at risk during interfacility transporters, but transport staff are as well. We recognize that the EMS workforce is a workforce that has a high risk of injury compared to the general population. U.S. Bureau of Labor says 2.5 times. The CDC says that's closer to 4 times the general population. 7% of those injuries are caused by violence or assault, mostly by the patient, where overall occupational, that's usually 1% caused by violence. And then occupational fatalities for EMS is 6.3 per 100,000. That's 60% higher than the overall rate. So again, it's very important that we're identifying and supporting of these. So what are some best practices? So I just don't want to share all this necessary scary data or humbling data, but then what are those? So first off, it's assessing and we're going to talk about each of these in a little bit more detail, but how are we going to assess agitation and risk of violence? And what are the evidence-based protocols that we can put in place? Our next slide will talk through those. What is the utilization of telemedicine? So this is a primer for our session in May, but how could telemedicine be used? We think of telemedicine, or at least I do. I think of telemedicine a lot as the outpatient setting, but how could that be utilized in the inpatient setting for interfacility transfers um, of behavioral and mental health patients and keeping patients in the facility they are? What are the laws regarding psychiatric patients and psychiatric care? That's very different than some other things. And then lastly, when and is it ever necessary to use restraint and sedation as other techniques and methodologies to ensure that patients and transporters and those receiving the patients are kept state? So first off, how do we assess those things? So these are our evidence-based best practices. We're happy to share these resources to you. But as many as 1.7 million agitated mental health patients visit the emergency department every year. Agitation is strongly associated with an increased risk of developing agitation that leads to violence, which is why it is critical to assess patients and maintain safety. There are several validated tools that have been developed that can be quickly administered. Some of these tools take less than 3 to 5 minutes. They primarily include the agitation severity scale, the behavioral activity scale, the Vorsa violence checklist. A couple that we don't have great time on is the McNeil Binder violence screening checklist, the overt aggression scale, and then there's the overt agitation scale. So again, tools as you're thinking of these interfacility transfers and what are the things that we do. Is it appropriate to do an assessment on all interfacility transfers from an agitation behavioral activity scale? Is there a certain kind of patients or certain types of diagnoses that we would want to do different types of measurement on? And again, what is that protocol being established before the patient enters? So when they are coming in and the ED is in that situation at 2 a.m. and they have a patient, they immediately know what tools or the workflows are already built into the EMR to support that. It's also important to ensure that the huddle is done. The huddle is a common element in agitation tools that reduce danger, studies show. So the only practice these tools have in common is convening staff to discuss risk before the transport begins. A review of best practice from a variety of institutions was a huddle right before departure Huddles should include all sending hospital staff involved with the patients and nurses, physicians, or providers and others, as well as the transport team. And there's broad agreement that this brief discussion will decrease the dangers to patients and transporters. It also, if you have telehealth connections with the receiving facility, invite them into the huddle as well. So everyone from where they're coming from during the transport and where they're receiving are all on the same page, and answers and questions can be asked depending on the patient. Maybe you're doing that with the patient as well. So they're involved and they have the autonomy of that discussion. Maybe some situations where the patient is not the best to be partnered with that. Next, we're going to talk about telemedicine and telepsychiatry. Another way to reduce danger in interfacility transports is to avoid them when they are unnecessary. Telepsychiatry is the provision of psychiatric services by video conferencing. It eliminates the need for a physician to be present or a provider to be present, and is especially useful in rural areas that don't have emergency mental health care in the community. Research has shown that telepsychiatry reduces inpatient admission and visits to the ED. It is also associated with higher likelihood of patients' routine discharge and patients receiving follow-up care at 30 or 90 days post-discharge, whatever is best for them. It also reduces time spent in the ED by 3 hours. As you would expect, it reduces healthcare costs due to lower rates of admission and fewer transfers. It's also reliable and comparable to conventional treatments for diverse groups of people. And finally, patients report high levels of satisfaction with this. And again, we're going to talk a lot more about telepsychiatry, both from an inpatient and an outpatient setting in our webinar in May. But having this be there, or another best practice we've seen out there is facilities where they're using telepsychiatry and it's the receiving hospital that's providing that support, and they're involved from the very get-go of the patient coming in the ED and the initial assessment by the ED provider and the engagement of what is the story, what escalation points have occurred or de-escalation points have occurred, and what needs to be done as far as yes, they need to be transferred, or no, they're suitable to be kept in their facility and be followed up outpatient or be followed up as an inpatient. Sedation, there's a lot of discussion about sedation. I am in no means an expert on sedation, so please don't ask too many questions, if any, on this area. But there are medications, Haldol, Ativan, Versed, that are commonly used in facilities for the management of violent or agitated patients. Ketamine has also been used, but is controversial because there is a high rate of adverse events, especially when done in pre-hospital transport by paramedics. It also changes your level of transport need if some of these medications are being used. Drug selection, again, should always be done by your clinician team, and there should be a protocol in place there looking at the severity of agitation, the response to previous drugs, if known by the patient. Again, lower doses should be the lowest dose possible should be administered. And you need to consider what's the duration of the transport. So that, again, the staff that's doing the transport, if the sedation is there, that they're able to get the patient from point A to point B before that sedation may wean its effectiveness with the patient. But again, this is the discussion amongst the medical community, amongst your providers, your prescribers specifically about what is the best suit here. Also, your facility receiving them, receiving the patient, and what is the best situation for them as the patient comes back in. The other area, again, that is controversial definitely is a restraint and the use of restraints. Restraints is defined as any manual method, physical or mechanical device or equipment that immobilizes or reduces the ability to move his or her, sorry, typo, arms, legs, body, or head freely. Again, there's a lot of controversy over these because they can be coercive, they can cause injuries, they can cause more trauma, sometimes death. They also can maybe take away, it violates the autonomy and increases agitation. Mental Health America released several studies on this as well. And so there's no therapeutic value should be abolished except for very brief periods, only when necessary to prevent imminent physical harm. So Mental Health America is, there is no therapeutic value in using restraints unless it is a way to prevent immediate, imminent physical harm, both for the patient and for the one transporting. Sorry, trying to flip slides there. So if a restraint is warranted, if that is within your protocol, if everyone at your facility is in support about that, again, it's only using those facilities when there's a danger to themselves or others. Making sure that you're following the law around those and erring on that side of caution. that each one is individually tailored. Every attempt is maintained to respect patient's privacy and dignity, using that least restrictive method necessary in avoiding after de-escalation attempts, have been attempted. They should only be administered by trained staff who know how to work and monitor with the patient. Facilities need protocols for observation and treatment, and meticulous documentation is necessary. Again, this is in a partnership between the host facility, the receiving facility, the transfer organization that's doing that support the patient about when and how are they going to be utilized. Again, if a patient restraint is necessary if the patient is restrained in the sending facility, they also should be restrained in transport, is what the literature is showing. So some of the things that should be done to monitor that is structures, pardon me, should be adjusted, or gurney should be adjusted to the lowest possible setting. So if the patient were to become loose um, in there and fall off, that the fall is as minimal as possible. Caregivers or those who in the transport should sit behind the patient, not beside the patient. Staff should remain vigilant for signs of escape planning and ensuring the safety of all present. So other techniques have been like hybrid seatbelt style devices that are less restrictive. Hybrid seatbelt device is one where, once it's clicked, you need a key to unclick it. So the patient is in a traditional like seatbelt, but cannot self-release themselves from the seatbelt. So again, it's how do we maintain and support the patient's autonomy and dignity, but while keeping everyone safe. Again, protocols are necessary to support these things. There are a lot of laws and guidance. Again, we're happy to share our slides. A lot of these are hyperlinked, but there are these extensive policies regarding the restraints for healthcare facilities on the national level. The Joint Commission released updated policy for restraint and seclusion for behavioral healthcare and human service organizations in 2024. However, it is not clear if these apply to EMS facility transport groups. On the state level, Indiana code contains three brief sections outlining the case when restraints can be used, along with recordings and observational requirements. In contrast, the Indiana Administrative Code has detailed patient restraint requirements for private mental hospitals to become licensed. Department of Mental Health and Addiction within FSSA, Family and Social Services Administration, has a webpage outlining these things. And the Department of Health, Indiana Department of Health, has a Restraint Resource Center within the Long-Term Care Division, which is dedicated to reducing the use of restraints in healthcare. So again, happy to share with you these links and share this information with you as you're thinking through these things, all these different avenues and items that need to be considered when designing interfacility transfers. State Enrolled Act number 505, this passed law last session, so session in 2025, not the session that just finished a couple weeks ago in March. But in addition to hospital and healthcare agencies, EMTs can transport individuals directly into a mental health facility or urgent care facility. Written agreements are required in advance. This permits reimbursement for the transport. There are protections in the law of acting in good faith. And this was again in effect as of July 1. So as EMTs are out in the field again, working within your medical licensures, working within the support, but maybe it is best to transfer the patient directly to a mental health facility. I know in rural that may not be possible because of the guidelines of how close one would be and where they need to send for transport. But instead of that patient starting at a traditional ED or inpatient facility, going directly to that mental health facility. Straight protocols for behavioral health emergencies are unique around the world. So if we think around the country, so only 34 states, so 34 states responded to this, and not all states that responded had all of these things. So first off, study shows that 7% of all 911 requests are for behavioral health emergency. So there is a lot of need out there and support out there. The National Association of EMS Physicians decided just last year, again, 34 states report that had protocols in place. So 29 included verbal de-escalation, 28 had advised when to call in law enforcement, 22 had standing orders for antipsychotics or ketamine for allowing them, one authorized for a benzodiazepine, sorry, can barely speak that, and then 20 described unsafe restraint practices, and only 6 provide guidance on safe implementation. So again, a lot of work there in our EMS space. So if you are having facility transfers and you're doing that through your own provider, working within the National Association of EMS, and understanding what are best practices out there and what are things that we can do as well. State protocols are different. So states different have variations, allow local State protocols are only one of many influences on practice activities as well. So the state protocols have several limitations. One is the states differ on how much adherence of protocols are required from local entities. State protocols are not the only influence of local units. And three, researchers were unable to obtain protocols from all states. Still, a decade after, there's no gold standard, and there's a desperate need for evidence-based recommendations. So I know as we were talking with our partners at IDOH about this webinar and what to include, there's not a gold standard for us to say here's what to do. We want to give you things, tools of thought, and share the toolkit with you. If we look at data quality, on different areas, underreporting by facilities. NYC, New York City said that 41% of restraint episodes were never reported. EMS reports patients often turn away from mental health facilities due to restraint or sedation. So understanding what those are, and CMS is actively working right now on how do we clarify some of these policies, and how does CMS and state agency really support those things. And happy to have discussion under the Q&A as we have discussion. So best practice summaries as we're wrapping up today. Please be adding in your questions into the chat or the Q&A window. But it's important that we create screening criteria for EMS personnel to triage patients to the appropriate facility on initial patient contact to reduce unnecessary transfer layers. Again, how to identify patients, get them to the facility best for them. Encouraging partnerships with telepsychiatry services to reduce the need to transfer mental health patients. So once they are at our facility, how can we work at the top of our licensure and allow that patient to stay here in the safest possible way? Standardizing a best practice assessment prior to initiating transfer of the mental health patient. Having a scripted huddle prior to transfer, so if a transfer is needed, how do we ensure everyone is on the same page? Clarifying the laws and differences, whereas the Department of Health and the justice system interacts and intersects, ensuring everyone at our facilities on the same page. Suggesting a common equipment for the safe restraint that can be universally adopted between both the receiving and the sending facility if that is necessary. Then creating data sets to track the number of patients that are transported and or not allowed for transport from mental health facilities and the supports that we need as a facility moving forward. So with that, I want to thank again my team. If you'd like more information, if you like our slides, if you like a discussion, we have 5 additional slides of our references that we used to put this together, where some of the hyperlinks are in here. Please email us, and we're happy to send those. Our email is rural@purdue.edu. Several of us check that and would be happy to send those. Or if you'd like to reach out directly to me, or if there's additional training supports that we can provide, my email is cjmullen@purdue.edu. So with that, I thank you all and turn it back over to Allie for questions and answers. And if there aren't any, ask you to please wait another minute while we do our exit poll as well. Right on cue.
So I do have the post survey already launched here. So if you wouldn't mind, just 2 quick questions, if you could fill that out. Again, very, very helpful for our flex funding purposes, to be able to keep having these high quality, free educational sessions. If anybody does have a question, please feel free to use the chat function or the Q&A function. You can find those by hovering your mouse over the screen, or you can always use the raise hand function, and that will encourage verbal conversation and questions that way. We can unmute your line if you would like to use the raise hand function.